right, now we're going to be looking at chapter 20. This is the antimicrobial drugs. So an overview of antimicrobial drugs, these are what we would consider chemotherapeutic agents. Now, normally when you think of the word chemotherapy, you think about using chemicals in the treatment of cancer. But guys, chemotherapy or chemotherapeutic agents are anything that we use chemical-wise that treats any kind of disease. So it's used to treat infectious diseases by inhibiting their growth. Some examples of these are things like antibiotics. This is going to be used on bacteria, antivirals, which of course will be used on viruses, antiprotozoals, antifungals, and antihelminths. All right, and so these are all going to be examples, and they are going to be very specific to what is actually causing the infection. So chemotherapeutic agents need to have selective toxicity. All right, we do see that some side effects are still going to occur, but we want to have the least amount as possible. And so because of this, we want to make sure that that particular medication or that particular chemical is targeting really what we want. Is it targeting that bacteria? Is it targeting that virus? Instead of hurting us as the host, and to protect us as the host as much as possible. We want it to target only the pathogen, and hopefully it does not damage the host cell. It's easier to selectively target bacteria than protozoa, fungus, and helminths to treat infections. And why is this? Well, the main reason is because of the type of cell. Bacteria are prokaryotic cells. They lack a nucleus, whereas protozoa, fungus, and helminths, they have a nucleus just like us. So their cells are more similar to the host compared to the prokaryotic cells. Cellular structures are different in these prokaryotic cells, so we can target protein synthesis, or we can even target their cell wall, all right? Because if you'll recall, their ribosomes are different than ours, and cell walls are not found in animal cells. There are also some metabolic differences that we could potentially key in on as well. All right, so a quick review. Ehrlich and Fleming, they when we look at this, Ehrlich was the first to use chemotherapeutic agent to treat microbial infections. He is the one that treated syphilis with salvarsan. This is what they thought was the magic bullet of treating all potential infections. However, it does have an arsenic base. We also see Fleming. Fleming accidentally discovered penicillin. Some microbes naturally produce chemicals to inhibit growth of other microorganisms, and so these are why they're termed antibiotics. All right, so if you look here on the plate, you can see where some of them, as they're growing, are inhibiting the growth of the other bacteria around them. And this is how he accidentally discovered penicillin. Now, not all antimicrobial drugs are technically antibiotics. Some are synthetic that we have made in the lab, and any of these sulfa drugs are antimicrobials but not antibiotics because they don't happen naturally. Now, there are several types of microorganisms that do produce antibiotics. They are listed here in this table. Bacillus species can help. These are some gram-positive aerobic bacteria. They can make things like bacitracin, polymyxin. We also see that there's the streptomyces. These are filamentous fungus-like soil-dwelling bacteria. They produce more than half of the world's antibiotics. If you'll notice, it's a large group here that includes things like erythromycin, streptomycin, gentamicin. And we also see that there are also some fungi that can help with this, that produce antibiotics. Cephalosporium and penicillium. All right, these two are different types of fungus that actually can help produce antibiotics as well. All right, so these are going to be some key. The more and more we learn about fungus and bacteria, the more and more antibiotics we could potentially discover. Now, chemotherapeutic drugs are divided into two main types of coverage. They are either known as narrow spectrum or broad spectrum antibiotics. If you're looking at a narrow spectrum antibiotic, it's only going to cover one thing. And so if you'll notice here, this one that's marked narrow is penicillin. Penicillin is really good against gram-positive bacteria, but it does not touch anything else. Therefore, it has a very narrow spectrum. However, some of them are more broad spectrum, meaning they cover more things. Tetracycline is the one shown here. It can target gram-negative bacteria, gram-positive, and also the chlamydias and rickettsias. All right, so if you'll notice, majority of these are actually more narrow spectrum, but there are a few. And so a lot of times when a patient comes in and they don't know what the infection might be, this is why they'll put the patient on a broad spectrum antibiotic first, because it can potentially treat more things. So what are the actions of these antimicrobials? Well, some of them are bactericidal. They're going to kill the bacteria. Others are bacteriostatic, which means they're just going to inhibit the growth. Which would be best to treat an infection? Well, a lot of times our mind is to go to, hey, let's kill it, get rid of it. That's going to obviously help treat the infection better. However, the bacteriostatic is actually the best antibiotics. The reason is this inhibits the growth, which then allows your immune system the opportunity to fight the infection. If your immune system fights the infection, you now have a defense against it the next time that you are exposed. So this offers you the opportunity to have a natural long-term defense instead of just taking a medication to kill the bacteria. Now, of course, depending on which type that you are going to use is going to be based on the urgency. Is it a localized infection? Is it septicemia? Is it a meningitis dealing with the blood-brain barrier? What kind of antimicrobial are we going to give? Is it going to be an oral medication or is it going to have to be through the IV? And also the dosage is important. How often does the patient need to take it? How much? How many milligrams do they need to have? All of these things are very important to look at when we're talking about antimicrobials. Now, antibiotics can affect normal microbiota. This could potentially lead to opportunistic infections. And so this is why it's important to get on the right kind of antibiotic if at all possible, but it is still also important to finish those antibiotics. All right, so let's look at some actions of antimicrobials. What do they actually fight against? One of the first ones is that it inhibits cell wall synthesis. The point here is that the antimicrobial causes the cell wall to be weakened. Now, because the cell wall is weakened, this means that it is more prone to potentially being taken out by the immune system. Some examples of these that actually inhibit the cell wall synthesis are found in your textbook. You'll notice here in the chart it says inhibitors of cell wall synthesis, and it lists the different groups. We have the natural penicillins, so penicillin G and penicillin V. We have some semi-synthetic penicillins. These would be things like ampicillin, amoxicillin. We also have the cephalosporins located here. There's some also polypeptide antibiotics like bacitracin and vancomycin. And then there's also the antimicrobacterial antibiotics, example things like ethambutol. Now, when we look at this, guys, the penicillins are listed up here at the top, and it's a large portion. We then have the cephalosporins. The polypeptide antibiotics are used for Staph aureus, the antibiotic resistant strands. So vancomycin is used more commonly for that instead of some of your penicillins. The last group down here, the antimicrobacterial antibiotics, are going to target the myclonic acid in the cell wall of the mycobacterium, such as in like tuberculosis or TB. So with the penicillins, these are going to hit gram-positive bacteria. They're going to have a gram-positive coverage. There are 50 chemically related antibiotics that are part of this penicillin group. Penicillin contains a B-lactam ring. Some bacteria produce B-lactamase, which is also known as penicillinase, and this renders the antibiotic useless. So because penicillin has a certain structure, this B-lactam ring, if the bacteria has an enzyme to break that down, it can cause penicillin to be useless. Penicillinase resistant penicillins like methicillin, this one is taken off the market due to the methicillin resistant Staphylococcus aureus. All right, so some of these get removed from the market due to the fact that they can overcome the drug very easily. Other penicillin derivatives are broader spectrum. Some will cover some gram negatives, but they have to add galvanic acid or amoxicillin augmentin to the penicillin. The next group are the cephalosporins. The cephalosporins are similar to penicillins but have slightly different B-lactam rings. The first generation of cephalosporins are really good against gram-positive, so they have gram-positive coverage, but other generations are more broad spectrum, and they can also cover some of the gram-negatives. So if you look here, it shows you the first generation, second generation, third generation, and fourth generation. These are the different types of cephalosporins. Majority of the first, second, and third are oral. However, when you get into the fourth generation, these are going to be through an IV or a shot. Another action that antimicrobials can take against bacteria is they can inhibit protein synthesis. They can affect the translation process where proteins are not being made properly. Now, inhibition of protein synthesis is going to normally deal with the ribosomes. That's what they're going to target because the ribosomes are what come together with messenger RNA as well as transfer RNA in order to start making the protein. And so we will see that some of these antibiotics are going to mess with this configuration of the ribosome. It's either going to cause the tRNA to not fit properly, the mRNA not to come in, or the ribosome to not come together like it should. So again, in your textbook on table 20.3, it shows you inhibitors of protein synthesis, and it lists the different types of groups that are located here. So we have chloramphenicol. This is a broad spectrum. It's also potentially toxic. We have aminoglycosides. Some have serious toxic effects. These include streptomycin. It's a broad spectrum, including covering mycobacterium. We also have neomycin. This is a topical use, meaning on the skin, and it's a broad spectrum. And then gentamicin is a broad spectrum, which includes Pseudomonas species. Now, one thing to note about these, because they have serious toxic effects, we need to make sure that we maintain therapeutic ranges. This means that blood work needs to be taken pretty constantly to check for peaks and troughs, okay, when the level is high versus when the level is low. We want to keep the level pretty moderated throughout their treatment to where they don't have these really highs and lows, because the highs are going to cause potentially toxic effects, and the lows are meaning that there's not enough antimicrobial in order to fight the potential infection. The next one are the tetracyclines. The tetracyclines are not for children or pregnant women. They also affect the intestinal coliforms, so they're going to not only fight the potential infection agents or pathogens, they're also going to affect your normal flora in your intestinal tract. These are also broad spectrum. They can also treat chlamydias. They're found in animal feed additives. We also have the macrolides. This is like erythromycin. Erythromycin is important because it's an alternative to penicillin. If an individual is found to be allergic to penicillin, this is a good alternative, which has a good gram-positive coverage to it. Another action that an antimicrobial can take is that it can damage the plasma membrane. If it damages the plasma membrane, again, it's weakening the bacteria in order to give access to the immune system. The main group here is the polymyxin B. This is a topical agent, again, meaning it's going to be on the skin for superficial infections. However, it has limited use in order to prevent resistance. We don't want the bacteria to become resistant to it. Another action that we can take against the bacteria is that it can inhibit nucleic acid synthesis. This means it's going to interfere with either DNA replication or RNA transcription. All right, so it's going to inhibit these processes. Again, from these charts, we have a couple listed here that actually are part of this. We have the rifamycins. This is rifampin. This is going to inhibit the synthesis of messenger RNA, and this is an important treatment of tuberculosis. Quinolones or fluoroquinolones are another example. These are going to inhibit DNA synthesis. They're also broad spectrum, but these are going to help against urinary tract infections. Some antibiotics target the urinary tract specifically here, and one of them is the ciprofloxacin. This one you normally hear about patients being on Cipro when they have a urinary tract infection, and this is that antimicrobial. Another way is we can inhibit the competitive metabolic inhibitors. When you look here, it's going to inhibit the synthesis of essential metabolites, things that are essential that they need in order to survive. So when we're looking at these, are the sulfonamides. These are broad spectrum, and they're a combination that is widely used, and this combination is known as Septra. This Septra combination contains two types of antibiotics. So taking a look at the Septra, this is shown that it has a synergenic effect. The synergenic effect means that they work together. So synergy is when two drugs, when used together, have a greater effect than one drug used alone. The two drugs that are used in Septra are trimethoprim and sulfamethoxazole. And if you'll notice here, the synergetic effect shows you that when both of them are placed together, this middle portion is where we see that it's working better against the bacteria than when it was by itself. So a quick overview when we're looking at this chapter. Antibiotics target bacteria very differently. Some antibiotics have a broader range of coverage than others. So one of the main broad spectrum antibiotics we talked about was tetracycline. Erythromycin is used as a substitute for patients who are allergic to penicillins. Some antibiotics are used together as they have a good synergistic effect, meaning that they're better together. Example of this was the Septra. We also see the aminoglycosides can be toxic in the high levels, so it's very important to know that safe range that we can use them in, and this is why blood work with the troughs and peaks are important for this group. We see that some of these antibiotics are actually topical over-the-counter medications. This includes bacitracin, neomycin, and polymyxin B. Some antibiotics are used to treat UTIs better than others. Cipro is one of the good examples here. And there are certain ones that can treat mycobacteria. Remember, the mycobacteria are a little harder to treat, like things like tuberculosis, the rifampin, the INH, and the ethambutol. So we want to now look at the guide to antibiotic therapy. There's got to be some standardizations that are required in order for this to work. And one way that we want to test the sensitivity of antibiotics is through what we call the Kirby-Bauer sensitivity testing. This is going to be similar to what we saw with the disinfectants and antiseptics, where we're going to look for that zone of inhibition. When we place these discs that have the antibiotics present in them, we want to measure the zone of inhibition, and we're going to measure these in millimeters. So there are some tables that are standards that are used to interpret results, and depending on how many millimeters are present for that particular antibiotic with that particular pathogen determines if this is what we would consider an S, where the microbe is sensitive to the antibiotic, an I, where the antibiotic may be effective in vivo, and an R, where the microbe is resistant to the antibiotic. So it helps us be able to give them certain kinds of terms or labels. This also allows us to look at the minimal inhibitory concentration, or the MIC. This is the lowest concentration of an antibiotic that's necessary to inhibit its growth. All right, so we don't want less than this, but we also don't want a high level above this because it could become toxic. So when we look here, we can look at the concentrations of the antibiotics. Up here at the first level, we would see that these are resistant to these particular antibiotic because the growth is in all of the wells that are present there. We see in this case that this one is susceptible to the antibiotic even in its lowest concentration, because at the lowest concentration we see that there's still no growth present. And then over here we can see that this lower concentration, this is the lowest concentration that will inhibit growth. If you go any lower, the bacteria will still grow. This helps us be able to set those standards of those levels for the antibiotics. We also see that we can look at the minimal bactericidal concentration, okay, the MBC. This is the lowest concentration of the antibiotic necessary to kill 99% of the bacteria. So when we were looking at the last slide, we were looking at inhibiting the growth. In this one, we're looking at killing 99% of the bacteria. To do this, we'll do a series of dilution tests. All right, so they'll do a dilution of the antimicrobial drug concentration. They'll go through the process of diluting it and then also culturing it out until we see that there is no growth, that 99% of the bacteria is dead. It's important to determine the MIC and the MBC to avoid excessive use of expensive antibiotics and to minimize the chances of toxic reactions for the individual because large doses could cause major issues. All right, so in this particular example, guys, you'll see that when there's no visible growth here at 4, okay, at this dilution of 4, this is going to be the MIC, okay, where we're inhibiting the growth, okay? But on the other hand, when we get up to 32, this is the first time that you see no growth. So this would be considered the MBC. So some miscellaneous here, mechanisms of resistance that bacteria can have. One thing is it can block the entry of the antibiotic that you see here. So the antibiotic cannot gain access. If it cannot gain access, it cannot do its job. 2 is it can have inactivating enzymes. So the antibiotic gets in, but there's enzymes that break it apart and make it where it is neutralized and not used. Over here on number 3, we see that they can alter the target molecule. So the antibiotic is going to target a certain molecule, but they have altered it in such a way that the antibiotic now cannot work against it. Or we see that it can efflux the antibiotic, meaning that it can kick it out. It ejects it. Even though the antibiotic gets into the cell then kicks it right back out. So these are mechanisms that actually help the bacteria become resistant to different types of antibiotics. Now, one way to prevent this whole idea of resistance is not to misuse antibiotics. We want to prevent resistance. So antibiotics available without prescriptions in some countries cause some major problems. A lot of times that's because then you're self-diagnosing. You just say, oh, I need an antibiotic. You go grab one and it could be the wrong one. And so the bacteria that is causing the illness or the sickness is able to still flourish, but then you're killing off good bacteria. All right, so antibiotics should only be available through prescription. Antibiotic treatment used when not recommended or required. Again, you just feel like that you need to take some antibiotics and you do that. Or if you have a viral infection, but you don't want to get a secondary bacterial infection, so you start taking antibiotics. Again, should not be done. If the patients don't comply with the antibiotic regime as prescribed. Guys, when you get prescribed antibiotics, make sure you take it like you're supposed to and you finish it. The big thing that happens is we normally start to feel better, therefore we stop taking it. Okay, don't do that, because if you stop taking it, you could leave behind the more resistant strands. Also, supplemental antibiotics in animal feeds as prophylaxis can also be misused and cause problems. Aerosols created by healthcare professionals creates an unnecessary exposure to yourself via syringes. So what happens here is when we have antibiotics in a syringe and you're trying to get all of the air out, some of the antibiotic gets into the air, you breathe it in, and you are exposing yourself over and over and over again to these antibiotics, which potentially causes the bacteria inside of you to start to become resistant. We also see inappropriate antibiotics are used for the type of infection. As when antibiotics were first discovered, they thought they were the magic bullet and they would prescribe antibiotics for everything. Nowadays, they need to make sure that it is an actual bacterial infection before they start giving the antibiotic. All right, because if you have a viral infection, antibiotics are not going to help. If you have a fungal infection, antibiotics are not going to help. So it's important to know what kind of infection you are fighting. Many hospitals have committees to review the use of antibiotics. They can use what we call an antibiograms, where they're looking at these antibiotics. This allows us to give statistics that are unique for each hospital. It allows them to gather information to see if certain antibiotic sensitivity testing on pathogens needs to be done, to see why sometimes maybe they're not working like they should. It also helps us report the number of organisms isolated within a given time of a report. This lets us know the percentage of sensitivity to certain antibiotics. Were the antibiotics useful and helpful against the disease? This is normally reported quarterly, so every 3 months, and this aids physicians in selecting appropriate antibiotic therapy for in-house patients. All right, so this is going to be unique from hospital to hospital, but it does allow them to be able to cater that treatment to those people. The next thing we want to look at is antibiotic safety. For some antibiotics, they have toxic side effects. They could cause liver damage, kidney damage, hearing loss. This is normally seen in geriatric patients. They have a higher risk factor for this. We also need to note that some antibiotics need to be monitored within their therapeutic index. This is that whole idea of the peaks and the troughs. We need to make sure that the blood draws are required and they are done when they are supposed to be done. Okay, and this is especially important in things like gentamicin and tobramycin. We also see that some antibiotics affect contraceptive birth control. We've seen that lots of women end up getting pregnant, but they're on birth control. We'll come to find out it's related to when they were taking antibiotics. Some antibiotics cause hypersensitivity reactions. This is like an allergic reaction. This is seen sometimes with penicillin, also with some of the sulfa drugs where people are allergic to the sulfa. And some antibiotics are not recommended for children and pregnant women because based on their age, based on the fact that they have a fetus developing inside of them, it is not good for them to take those particular types of antibiotics. These last groups we're going to talk about are harder in order to treat because of the fact that their cells are very similar to our cells. All right, and so with wanting these medications to be selective, it's going to be a little harder to treat them. So looking at the antifungals, these typically target the sterols, which are the different lipids in the plasma membrane of the fungus. Also, some of them can target the cell wall since they have a cell wall and animal cells do not. There are some topical and some oral antifungals. With the topical antifungals, We have griseofulvin. This was produced by Penicillium. It treats superficial germanophyte fungal infections. We then have tolnaftate. This is found in tinactin, and you may have heard about this because the jingle goes tough actin tinactin. These are going to be topical type of creams and stuff to help treat topical fungal infections. On the other hand, some oral antifungals where we're going to have to treat things a little bit that are a little bit deeper seated fungal infections are going to deal with these oral medications. So ketoconazole is an oral type of antifungal, and so is amphotericin B. This is the amphoterrible fungicide. This one treats systemic fungal infections, so fungal infections that are more deep-seated, that are affecting multiple systems. Now we're getting to antivirals. Antivirals are particularly difficult to target because viruses replicate inside of our cells. And since they're inside of our cells, we have to have a way to get access to them. So the antivirals can target the attachment and uncoating of the virus. It could inhibit the DNA RNA synthesis of the viral parts inside of the host cell. One really good example of this is Acyclovir. We see that it also could prevent the spread to uninfected cells. An example here are interferons, which are natural chemical signals, also known as cytokines, that are sent from affected cells to unaffected cells. So this is what happens when a cell gets infected with the virus. It sends out interferon, and interferon tells the other cells that, hey, I'm infected, protect yourself. And those cells start to protect themselves. So these interferons are a good way for us to potentially use in order to help protect the neighboring cells. Right? So when we look here at these antivirals, there's lots of different examples. The first ones up here are the nucleoside or nucleotide analogs. These are going to target the DNA and RNA synthesis. And again, Acyclovir is one of the main ones that are prescribed. This will inhibit DNA and RNA synthesis, and it's very primarily used for the herpes viruses. All right, and again, there's some other examples as well. Some that are for the attachment and the uncoating. You can see that there's the zanamivir that's used here. It's an inhibit. It's going to hit the influenza virus, and this is used a lot of times to treat influenza. And then the interferons, like known as alpha interferon, are to inhibit the spread of the disease to new cells, and this is the viral hepatitis that we would look at that they use to treat here. All right, so these are the antivirals, and again, they're a little harder because we've got to target the different ways that the viruses utilize the cells. The next group are the antiprotozoans. This group is going to target things like diseases that are things like malaria, amoebic infections like amoebic dysentery, giardias. These are all going to be things that are caused by types of protists. So we have quinine, chloroquine, metronidazole, also known as, and the main brand of this is known as Flagyl. These are going to be things, again, we'll talk a little bit more about later. The last group are the anti-helminths. These are going to be the ones that fight against worms. There's multiple types of anti-helminths, but a lot of them are going to be used to prevent ATP generation of the mitochondria, alter the permeability of their plasma membranes. It may block their neuromuscular areas. It may inhibit the ability to absorb their nutrients. The one that is really important is the ivermectin. It's down here at the bottom, and the reason it's important is it is to paralyze the worms. And so when we look here, this is against intestinal roundworms primarily, and it's occasionally also used for scabby mites and also lice. And so it has more functions. Some of the others are going to use for roundworms, but others may be used for tapeworms. But these are different medications that could be given to help fight worm infections. All right, so this finishes up our talk about antimicrobial medications. We focus mostly on antibiotics in this chapter. However, some of these other medications are going to come up when we start talking in the next unit about all these different diseases. So again, if you have any questions, please let us know.